So we're going to hear from Allon Barsam about the latest clinical data, because when the Galaxy launched last year, we didn't have a whole lot of data, and there's going to be some peer-reviewed data coming out. Basak is going to be talking about challenging cases of putting the Galaxy behind eyes that might have had laser. Tabitha, she's going to be talking about some new technology from Rayner about eye journey and collecting patient-reported outcomes. And I think Roger's going to bring up some very interesting things where probably the comparison you want to see, which will be Galaxy versus a trifocal lens. So we've got some really interesting things in the next hour. So there's been a lot of interest about Galaxy over the past few months. I don't think there's been a product with this much hype, this much excitement, this much of a revolutionary step since trifocals, really. So Galaxy really is what we've hoped for, a refractive lens that offers a full range of vision. There's been a lot of publications, a lot of media about it. So exciting to get down to actually peer-reviewed data. In terms of what it can achieve, like I said, a full range of vision without diffractive rings. This is a spiral optical design, and the design was in collaboration with AI. So the design has been able to put quite a complex combination of optical features into a relatively simple to use lens. So it is providing a full range of vision, and we're not getting the same dysphotopsia profile that you would with a diffractive IOL. So it's exciting to see. So we'll get right into it. I'd like to invite our first speaker up onto the podium. It's Mr. Allon Barsam, a cataract, cornea and refractive surgeon from London. He's the founder and director of OCL Vision, and he has the privilege of being the very first implanter around the world of the Galaxy and the Galaxy Toric IOL. So if you could all join me in welcoming to the stage.
Today, I'm going to be talking about the 6-month follow-up, which is longer than what we have published, from surgeons, including myself, across 6 sites, and also including Tiago, who sadly passed away a couple of months ago, also contributed data, and he was an excellent colleague and friend. The subjective refraction that we see at 1 month, 3 months, and 6 months, you can see here for sphere cylinder is very tightly controlled. And it levels off at about -0.2 at the 6-month time point, and the main reason for that is that this includes data in the very early implantation where we had yet to optimize the A constant. So now with an optimized A constant of 118.4, we would expect it to be much closer to 0. The binocular visual acuities at various distances, you can see both corrected and uncorrected. And again, you see some improvement here between 1 month and 6 months, especially for distance and intermediate. And there's also an improvement in near, by the way. But there are some reasons for this. I think for the distance visual acuity improvement, it's likely to be neuroadaptation. So it is not uncommon for patients to feel that the distance vision is blurry in the early months, and that goes away with neuroadaptation time. Cumulative visions here, you can see 100% of patients are achieving functional vision at all ranges of vision, which is why this is categorized and used as a full range of vision lens. And the vast majority of patients are logMAR 0.0 or better for distance, at intermediate and near. So a very strong performance across all distances. This, I think, is the most exciting thing about this lens, because you'll be familiar with the kind of typical 3 peaks that you have in trifocal lenses, and you don't necessarily measure that in your clinic normally. You just ask a patient if they can see it. You might measure distance, you might measure near, you might measure intermediate, but you don't measure, are there areas in between when things are blurry? But I've had many trifocal patients telling me that when they're approaching a shelf in a shop or something, that things basically come in and out of focus, or they might have to move their computer screen because 60 centimeters isn't right, they need it to be at 50 or 70. And that kind of stuff is annoying from day to day, because you can't always fix the distance at which you view things, whereas this genuinely continuous range of vision, which looks a lot like the defocus curve you might expect in the natural lens of the eye, is very meaningful for patients, and it means that their reading speed is quick. They're not having to spend time trying to figure out where the right distance is to hold things, and the intermediate vision is superb with this lens. We did a comparison, comparing this lens, comparing what we published with this lens with published data in other commonly used diffractive trifocal lenses. And it is difficult to compare patient-reported outcome measures across studies. We use the one parameter that is, I guess, easy and consistent to compare across, which is just whether patients reported any level whatsoever of bothersome halo and glare. Now, this is not significant or extreme halo and glare. We know that with many trifocal patients, most trifocal patients, in fact, are really delighted and happy with it. But you can just see just a huge difference in the patients experiencing any level of halo and glare with Galaxy compared to the trifocals, which is a huge advantage of this technology compared to what's come before. We only had 40 patients reporting on their satisfaction out of the 100 that we're presenting here, but they all would recommend the lens to friends and relatives. So in conclusion, we've seen excellent binocular vision at all distances, with stable results from 1 month up to 6 months. There's a full range of vision and continuous and smooth full range of vision within about a 4 diopter range at 0.2 logMAR or better. Significantly less bothersome visual disturbance in terms of halo and glare than diffractive trifocal lenses, and a high level of satisfaction. And I can tell you that in my practice, where I personally have put in over 300 of these lenses, many patients now coming in informed by artificial intelligence on what the different lens options are, told by their friends about the technology that they had. And even if we as surgeons don't want to necessarily discriminate on technology, patients are doing that anyway, and they're coming in and asking for the Rayner Galaxy lens. They don't want the glare and halos that they've heard it occurs with trifocal lenses. Thank you very much.
Thank you, Ben. Thank you all for being here this afternoon. So as you all know, the consideration of multifocal IOLs in post-laser refractive surgery eyes is very challenging because there's an increased risk of biometry inaccuracy. The corneal surface will be altered with induced higher order aberrations. There can be an ocular surface instability. What about the angle kappa and angle alpha susceptibility in these patients? And we all know that the diffractive multifocal IOLs have a reduced tolerance to dysphotopsia. And all these factors may predispose to refractive surprises and suboptimal visual outcomes in our patients. So the question is Galaxy's non-diffractive spiral optic a suitable option for those patients? So in our study, we implanted Galaxy and Galaxy Toric in 22 eyes of 11 patients with a history of myopic LASIK. 10 were a refractive lens exchange and 12 were cataracts. And of course, we have a strict exclusion criteria here. We excluded eyes with decentered ablations, post-refractive surgery ectasia, any eye with ocular surface disease, and we evaluated the higher order aberrations, and we excluded eyes with total corneal higher order aberrations more than 0.5 microns and corneal spherical aberration more than 0.6 microns at a 6 millimeter pupil. We did our IOL power calculations with Barrett-Ruhe formula, and our outcome measures at 3 months were refraction, uncorrected distance, and corrected distance visual acuities, uncorrected intermediate and distance-corrected intermediate visual acuities, and uncorrected near and corrected near visual acuities. And we evaluated the patient-reported outcome measures with dysphotopsia. So, coming to our results, the subjective refraction pre-op versus post-op at 3 months. As you may see, the cylinder and mean residual spherical equivalence were, of course, showed an improvement after IOL implantation. You may easily see that all of the eyes were within plus and minus 1 diopter after 3 months. And the postoperative cylinder and mean residual spherical equivalent distributions were narrowed, indicating an accurate refractive landing even with eyes with refractive laser surgery. But keep in mind that for the ones who are not working with optometrists and who are doing their refractions on their own, do not rely on your autorefractometer printouts, because these printouts really overestimate myopia by approximately 0.7 diopters in a population like this. So as always, if you are using an advanced optic in your cataract surgery, never use your autorefractometer printouts. What about the visual acuities? So compared to pre-op results, all uncorrected monocular mean visual acuities showed a significant improvement, and all were strictly below 0.1 logMAR. What about dysphotopsia assessment? So what we did is we asked our patients to grade their dysphotopsia, starting from 0 to 5, 0 having no dysphotopsia and 5 having severe dysphotopsia, like you would do in an ER for pain grading. So 50% of the cases said they had no dysphotopsia at all, and the other 50% said they would score their dysphotopsia between 1 to 3, stating that they had mild dysphotopsia. And one case had a very severe dry eye amongst these patients, grading his dysphotopsia as 3. And a severe or very bothersome dysphotopsia were not observed in any case we did. What about the correlation analysis between angle kappa? So there was no significant correlation between preoperative angle kappa and postoperative uncorrected distance visual acuity or dysphotopsia. And in our study, when we look at it, eyes with larger angle kappas also showed very good uncorrected distance visual acuity with mild or no dysphotopsia. What about angle alpha? Again, no significant correlation between preoperative angle alpha and postoperative uncorrected distance visual acuity or dysphotopsia. And again, eyes with larger angle alphas showed very good uncorrected distance visual acuity with no or mild dysphotopsia. What about pupil size? As you may see, we have fairly large pupils in this study. Again, surprisingly, no significant correlation in our group between pupil size and postoperative uncorrected distance visual acuity or dysphotopsia. And eyes with large pupils also showed very good visual acuity. So this pupil independency may imply a reduced risk of potential lightning-driven fluctuations, more consistent visual quality from photic to mesopic conditions, and maybe an easier counseling with our patients. So to conclude, there was a high refractive predictability and effective cylinder reduction in our post-laser patients. The visual acuities indicated a good correction of the intermediate and near function to levels consistent with spectacle independence. And stable distance vision across wide angle alpha and kappa angles and pupil ranges were observed, supporting predictable outcomes and broad patient suitability. And there was no or mild dysphotopsia symptoms reported, even with increasing angle alpha, angle kappa, and pupils under mesopic conditions. So it seems that RayOne Galaxy is a good option for eyes with myopic laser refractive surgery history, restoring vision at all distances and inducing no or little dysphotopsia. Thank you.
So Allon has already mentioned that the Galaxy patient is a different sort of patient you need to counsel. And I'm going to talk about how we do this in our clinic and how we sort of used a new device in order to collect our PROMs. So when matching a patient to your IOL selection, you have your IOL portfolio. You always think about what are their expectations, what they're looking for, and how can they match that, or how can you match that to your IOL portfolio? And the measurements are quite something you need to look at as well, because you know what the patient wants. You've matched them, for example, to the Galaxy lens, and obviously you need to have the right measurements. So we've known now from Basak about cases such as post-LASIK. We look at higher order aberrations as well, spherical aberrations, and just in general, healthy eye. And what we have learned is also to really focus on the medical history. Something like neurodegenerative diseases are really important to look out for, something like morbid Parkinson's. So keep in mind that and really look into this medical history. All our patients who are getting a Galaxy lens and have a good enough vision, or refractive lens exchanges, we sit in front of the Ralph device. So if you have a chance, please go and look at the Rayner booth. They have the device there. It's a device where you put in the real lens in front of the eye. So it's not a simulation. You really look through the lens. You can see what the difference is through diffractive trifocals, for example. And there's a study that has been done, which has sort of trying to see what patients actually, what their preference is through all the distances. If you look at it at the distance, at the range of focus distance, intermediate and near, they were chosen quite often, 80% and more in every range of focus. If you matched it to a diffractive trifocal, the Galaxy was preferred. So it's really nice to see, and I highly recommend you do this. And we do this with all our patients as well. However, when you counsel your patient, there's still a lot of issues because 80% of your information you're giving to the patient is lost. They walk out of your clinic, they don't know what you were talking, or they forgot about most of it. And because they don't know what's going on, they're quite anxious. They don't know what's happening. So 50% of these patients are very anxious about the surgery they're having. And because they're anxious and because they don't know what's happening, they're not that willing to adhere to your pre- and post-op checklists you do. So that's quite a big problem. So what we have started doing in our clinic just a couple of weeks ago, we introduced iJourney. iJourney is an app that Rayner has helped us to sort of individualize to our clinic. And the app really helps you to educate your patient correctly. It's really nice because all the information is stored in there. Everything they need to know is stored in there. So what can you do with this app? If it's allowed in your country, in our country it's not allowed yet, but you can do your informed consent there and it's stored there. They have appointment reminders and they know where they have to be. It's really, really helpful in this. And this is something I really enjoy having is the pre- and post-surgery checklist. There's lots of bureaucracy happening. They need to bring lots of things when they come to your operation. And finally, there's a checklist they can use, and it's really, really helpful. If they have questions, they can chat to you. They can answer these questions directly, building more trust into your clinic and the surgeon itself. Drop compliance tracker, because they don't know what's happening, they don't adhere to their treatment post-op. And with the drop compliance tracker, they actually have push notifications for this. And something you can really individualize to your own clinic, to your own workflow, is the structured patient education. And they have videos they can look through. A week before, what's happening, at night before the surgery. They know you're anxious, and they have a nice video knowing this is what's happening, just calm down, it's gonna be okay. Because after all, for us, it's day-to-day business. We know what's happening, but for the patient, it's a once-in-a-lifetime experience, and you really need to sort of help the patient help through this iJourney. So what helps with the iJourney is they know when they have to be when and where. They know what's happening, so they're more likely to trust you. They're more likely to adhere what you tell them to do, because you have the increased patient understanding. And then they're less anxious and they have more trust in you. And that's, after all, we want to have good success. And with this, it's actually helping you a bit more to get this success. And another part that's helping you to collect the PROMs quite well is that Ray Pro is actually integrated into iJourney. So you can have the questionnaire from Ray Pro, it's integrated in there, they get a push notification, and no matter where they are, maybe they're just sitting in the metro on the way to a conference like this, and a notification pops up, and they maybe just quickly do the questionnaire, and there you've got it. It's really helpful to collect those PROMs quickly and efficiently. So in conclusion, what's it doing with our clinic management so far? It really has helped sort of standardizing the process even better, no matter for which patient. And for the Galaxy patient, this is really important because it is a different kind of patient you counsel. For our administration, it has helped a lot. In Germany, we have a lot of bureaucracy happening. Lots of documents happening. So for us, it's really has helped sort of reducing that and finding more out about these PROMs, easily collecting them. Really helped us change quickly new workflows and implicate new workflows in our clinic. And for the patients, they're less confused. That's nice. They're less confused. They have trust in you. They have a better experience because it is a once-in-a-lifetime experience and something special. You want to sort of help them get through it. And they're more likely, if they're happy, they're more likely to help you collect those PROMs and help you even improve your practice even better. So it's a really nice feature so far we've used. Thank you very much.
Thank you. Thank you very much. It's a great pleasure to share a podium with these great friends. And I would start asking you to please bring a round of applause to Rayner for finally bringing something different to this amazing market. Could you? They really deserve it. So, whenever I think on comparing lenses, and reality is lenses are really good today, we have really get lots of varieties, it's not that easy, because if you see just the numbers, we kind of think of numbers talk. Yes, but patients do talk too. I want to listen to them. I want their feedback. I want their patient-reported outcomes. It's a combination of both things. Of course, I like understanding what is the range of vision of each IOL, how they are performing in far, near, intermediate, and what is the predictability of the platform, the consistency. I want to do every time the same. Don't have surprises. But patient-reported outcomes is absolutely mandatory in today's practice. So understanding how they perform in their daily activities and their photic profile is very, very important. And moreover, I want to look how their eyes are bright, how happy they are next day, not in 1 year, next day, 1 week, 1 month, because this is very important for word of mouth and for having extremely happy patients. So to do that, we carried on a study, a single-center study in our clinic, prospective, comparative, with this amount of eyes, 48 eyes from Galaxy, 48 from EDOF, and 44 for trifocals. I'm sorry, today I'm not going to give last names. I'm just going to go to show you EDOF and trifocals. They are the gold standards or the most used. I'm going to be polite with those companies because I am a good friend and they are very good too. Sorry for that, my friends. But the idea is I'm going to share 1 month data. Of course, it's an ongoing protocol. And we targeted the metropia, minimum of vision in the EDOF, in the non-dominant. And these are the criteria. We went for visual acuity, PROMs with Ray Pro and Revi. And of course, I'm going to share all this one by one. We're going to walk through each stage. So regarding monocular, uncorrected distance visual acuity, it showed comparable in Galaxy and trifocal groups. They both targeted for emetropia, very comparable in terms of performance is uncorrected monocular. And Galaxy truly showed that it's highly effective and safe for distance visual acuity restoration, which is really good. Understanding that the patient has consistent far, for me, is a starting point. Regarding monocular intermediate and near, the Galaxy, and you have a distance-corrected intermediate visual acuity and distance-corrected near in the right, they all showed excellent restoration of intermediate vision to a level comparable to the trifocal and EDOF groups, better functional level of near vision achieved with Galaxy compared to the EDOF. And we will see this very clearly with the reported outcomes too. So very similar near between Galaxy and trifocal, slightly better in trifocal, but this is not exactly what the patients are perceiving, but much better than the EDOF. And this is where the things start getting much more interesting. This is the questionnaire that is exactly the same that is the one provided by PROMs, by Ray Pro. We actually copied, sorry Stan, are you Stan there? Oh, there you are, Stanley Windsor, a great friend and the guy behind Ray Pro. I copied exactly the same because I wanted to have a point of reference. And this is the spider web that we provide in order to understand the outcomes. The worst is the closer to the center, the best is the closer to the periphery. So if I share you the prior you don't know, we need to understand compared to something. So in this very easy question, performance at near, how often would you wear glasses for your near distance activities, example reading using a mobile? You can see in this spider web, as you can see here, that the trifocal slightly but very comparable to Galaxy there, far away from the EDOF. So there is definitely an improved performance at near task compared to EDOF, and really high scores ranging from 8 and 8 found in both Galaxy and trifocals, and very, very comparable to a trifocal. Extremely good intermediate, as was stated by my good friends before. Very high levels of spectacle independence for distance and intermediate tasks, and similar to that achieved with trifocals and EDOF. Very similar. You see that they converge all in the same place. Regarding numbers, because it's even easier if we translate this to numbers, spectacle independence is really impressive. We have even slightly higher to the trifocal, combining the three distances, very high spectacle independence rates with the Galaxy and trifocals, slightly lower with the EDOF IOL. If we start speaking a little bit about disturbance at nighttime, the most important driving, you can see that there were similar levels of night driving dysphotopsia to the EDOF, as you can see there. They are both exactly the same, very similar, and you can see the difference, much less disturbance during nighttime driving compared to the diffractive trifocal. We have a favorable night driving profile with the Galaxy. And this is in numbers, again, very similar. Galaxy 22%, EDOF 20%, trifocal 29%. Those are more or less the percentages of how they are disturbed, which is interesting to put it in numbers. In terms of satisfaction, we have an average of 88 with one of our trifocals, 89, 90, 91, but not much more than that. It's always ranging among those with different models. With the EDOF, it's almost more or less the same, but for the first time, we are penetrating the 95% of patient satisfaction. It has been very surprisingly for us, because we know that there are many, many variables implied here, and we are consistently getting very, very satisfied patients, the highest that we have ever experienced to this point, to this early point, but there are 48 patients is something that is at least to respect it. Excellent visual acuity at all distances, highest spectacle independence score versus other presbyopic correction IOLs. This photopsia score is comparable to an EDOF IOL. I think we are all doing EDOF, I guess, to have a reference point that we are performing extremely similar to them at nighttime is really good, because that was an upgrade that we did from other lenses, and we definitely have less photic disturbances during nighttime driving versus a diffractive trifocal. Just to finish, I think it has shown the highest overall patient satisfaction, which for me is really, really important. Thank you for your attention.
So I'd like to go through the panel, and maybe we could start with you, Roger. Is there still a time to use a trifocal lens?
I'm going to be non-political, as I usually am. Sorry, I think it does. I think trifocals still have some place, but it's true that I think that Galaxy is going to get a lot of that share, And if you want me to be specific, I think that if there is someone that is not driving and they want extremely strong near vision, I still think that it provides slightly more. Sorry for being non-political, but in the overall, I think it's demonstrating very high patient independence, and for the modern praxis, I think the Galaxy will start eating most of what we do with trifocals. So,
it makes sense. Tabitha, would you feel the same?
So far from our clinic as well, because we are starting to use the RALPH, and there are other lenses in there as well. As far as we are starting to learn a new workflow, because the patient actually chooses the lens, and not we choose the patient for a lens and for a patient anymore. For the cataract patients, we can't use a RALPH, but the patients who have good enough vision, it's quite interesting to see that the people who chose it's actually mostly the Galaxy rather than the trifocal. So it's still early days for us as well with the device, but it's heading that direction.
And Basak, for post-laser eyes, a little bit different question for you. Are there any other lenses you would use behind a post-LVC eye?
Of course I do. So as you all know, Galaxy has a negative spherical aberration control, whereas in post-hyperopic eyes, we would need to have a positive spherical aberration control. So I will go and look at the spherical aberration. So, because in most of the eyes, the refractive correction being made is not huge, so you can still go and play with Galaxy or other, neutral spherical aberration lens. But in certain eyes, you definitely need some positive spherical aberration to have a visual quality. So I go with EMV, of course.
And Allon, in your practice, you've had a bit of experience with EMV and Galaxy. Are you finding that you're still using both lenses?
Yeah, absolutely. I still really love the EMV. If it's a kind of cataract patient, not demanding, full range of vision, not demanding total spectacle independence, where maybe the ocular surface isn't so good, maybe there are kind of subtle irregularities on the cornea, maybe even the macula doesn't look fully pristine. They're 90 years old, they're a super high myope. There are so many factors where you really feel like you want to optimize that point source of light onto the fovea, at least I do, especially in that kind of group of patients. And I absolutely love the EMV for that. And if they do want spectacle independence, then I'll offset the non-dominant eye up to -1, sometimes -1.25. And you can see, the simulator, I do encourage you to go and have a look on the stand. They'll probably be overwhelmed after, Tabitha's excellent presentation. But you really do get a feel for how unbelievably good the distance vision is with the EMV. So I would say for my cataract patients, it is still my go-to lens. And I really love it. However, with lens replacement patients or cataract patients that are asking or wanting full range of vision and total spectacle independence, then the Galaxy fills a niche like no other. And it's, it's just fantastic to have something new that we can use now that wasn't available before, with all the advantages that you've heard.
And I think probably one of the things that impresses me the most has been the dysphotopsia profile, the lack of dysphotopsia, or the low amount of dysphotopsias. If you had a patient that was particularly concerned about dysphotopsias, or maybe even a patient that already has a trifocal and doesn't like dysphotopsias, would you put a Galaxy in, maybe start at your end, Roger?
Absolutely, absolutely. It's really very nice photic profile, and I wasn't able to show you the 3-month data because it was a more reduced N. But something that is calling my attention, I would like to mention, it is how fast they are improving. Because one thing is to feel some disturbances, as I shared, 20%, which is 22, is very low compared to another EDOF, one of the most used. But then, after 3 months, it's getting extremely lower compared to a trifocal. It's not only starting point, but then the evolution is nicer. So which means that this neuroprocessing and this neuroadaptation is really happening, and it's a very natural lens I feel that the patients can deal with it very easily.
Basak, with counseling patients, if we were counseling someone that's had previous laser surgery and we're putting a trifocal in, there's quite a lot of counseling. They're going to expect halos. It's going to be maybe less accurate, a risk of doing more laser. How are you counseling people differently when you're putting a Galaxy lens in? Are you doing anything different?
To tell you the truth, I am trying not to do anything different, to be on the right side. But as you said, counseling post-refractive surgery patients is very tricky because to start with, they can have some higher order aberration-induced dysphotopsia. So I try to see whether they have these dysphotopsic, problems before their surgeries, and is it related to the lens? Because they can have some, lens problems. Then, they don't have to have a cataract, but if you have it, the problematic lens inside, which is, thicker, and after your 50s, there's dysfunctional lens syndrome, which can induce some, aberrations that is not related at all with their corneas. I try to figure out if it is related with the cornea or the LASIK or the lens itself. If it's lens related, I am relieved and proceed as I would do with any other Galaxy lens. But if it's related with the cornea, I am very selective with the words I am choosing, and I am just telling them that these dysphotopsias will stay. Even if you put the monofocal lens inside, they will, like possibly are staying with those dysphotopic problems. So it is really, really very important to counsel the patients right if you don't want any problems afterwards. This is not a diffractive IOL optic, so it will not induce the rings and halos that we are familiar with any diffractive IOL optic. But garbage in, garbage out. If you have a bad cornea, you will have problems afterwards, even if you put a monofocal.
And Allon, right at the start, you indicated that you do counsel these patients a little differently, or maybe select them differently to your trifocal patients. So can you tell the audience what you're thinking there?
Sure. So, selection actually I think is quite similar. I think you can select patients for Galaxy that you would select for trifocal, and be careful about selecting patients for Galaxy that you wouldn't select for trifocal, maybe with the exception of these post-LASIK myopic eyes. But in terms of counselling, I think there are 4 things that's very important to communicate to patients, some of which you would also communicate with a trifocal. The first is distance visual acuity, or more important, how they perceive their distance. So the majority of patients don't complain or are not bothered by any distance vision problems after Galaxy, but around a third in my practice, and that's a lot of lens replacement, kind of highly demanding patients, will say that they feel that distance vision is blurry. And that's despite good visual acuity, good contrast, a clear capsule, good ocular surface, 0 refractive error, all of those things, they just perceive that it's blurry. And then it's almost like a switch flips in the brain. And there's been, a lot of discussion in the past about whether neuroadaptation is real with, the previous technology like trifocals, or is it people just getting used to the vision not being good? But with Galaxy, I really do feel like it is a genuine neuroadaptation process, because they can come at 2 months and tell you they feel like the distance vision is blurry, and you see them at 4 months and they say everything's great, and literally nothing's changed except for 2 months of time. So you have to absolutely counsel them that it's going to take them a while to feel comfortable, happy, and satisfied with their distance vision, but they are fully functional often 2 or 3 days after surgery. They've got perfect distance vision for driving, working, doing everything they need, but they might not be satisfied. And there are many examples of that with monovision, with other interventions that we do. So that's important, and that, in my opinion, is a very small amount for the surgeon and the patient to put up with compared to a lifetime of glare and halos, which is the alternative with trifocals. I do mention glare and halos. I tell them that there's a 50% chance you won't get any glare and halo, which is you've seen in the studies that have been presented. 50% chance you will get glare and halo, but it'll be mild and non-bothersome, and that's true because they're just not complaining about it. I tell them about there's a chance they'll need YAG capsulotomy, and I tell them the ocular surface needs to be good, and if necessary, treat the ocular surface. So, and then there's a near vision expectation. They must not expect to be able to see unaided perfectly for near at 25 centimeters, because this lens is designed from 40 centimeters, a comfortable working distance for near, into the far distance. And I think providing you explain and communicate that to your patients, they are super happy, super satisfied. And it is, again, go onto that simulator and have a look at what the nighttime vision is like with a trifocal. It's just, it's so just, start using this lens and it is better, because that glare and halo never goes away. You could see them 5 years later and they've still got that. That's there for their lifetime.
Let me piggyback on that, because I think it's really important, because it happens that at the beginning it's true that the constant wasn't that optimized, and the first initial patients were slightly myopic, and it happened that those were the few 7s that we received in terms of satisfaction at the beginning at 1 month. The beauty of this, and is what I started building a lot of confidence, is that those 3 or 4 patients that were have scored 7 at 3 months, they did 9 and 10s, which was really pumping in my confidence, and that's where I started being more and more aggressive, because I realized that this was happening. It's true. These patients were extremely quick adapting to this new situation. Just one more phrase, and I don't take it. The value proposition is very clear. The value proposition is that you are somehow dealing with an EDOF, the best of the EDOF, and the best of the trifocal. What is the best of the EDOF? The photic profile that we know is lower, the contrast sensitivity, easy neuroadaptation, and what was the best of trifocality? The independence of spectacles. We have both of those words in a very balanced way. So it's very easy value proposition to perceive, and that's why patients are so happy.
Before we finish the session, would each of you like to give the audience sort of your best tip or your best bit of advice or anything about using Galaxy?
I've just done it, so I leave it for them. I don't want to monopolize the microphone.
Tabitha, what would you say if you had to let the audience know one thing about your experience. Could be with iJourney, anything you like, really.
So far with our journey, if you want an easy way to collect your PROMs, which is fun, it's a lot of work, and it's a lot of fun work though, but if you want an easy way, go have a look at iJourney. If you're there, have a look through the ROF device, and you will see what the bus is all about.
And Basak?
So Ben, I think Galaxy is a beautiful lens, but as any other beautiful lens, you will need and also a good healthy cornea and a healthy retina to make it value. So you need to go and check if your patient is eligible for receiving any kind of full range of field lens, and then proceed. It is not a monofocal lens that you can easily pop into a geographic atrophy.
And Allon, any other tips? You've given us a lot, but anything for the road?
Just, yeah, I mean, the final thing, and I tell this to all of my any presbyopic treatment I do, is I always say to patients, don't expect to have the kind of vision you might have had when you were wearing glasses when you were 20 years old. Because I think some of them come into the clinic with that expectation in their mind that somehow you can give them perfect vision from day one without anything else required on their part or any kind of adaptation or further treatment. So it's important to set, realistic expectations. But certainly, for full range of vision, I think it's currently the best thing that we have.
Yeah, I love it. It's a great lens. So if anyone wants to, come and have a chat to the panel members after this, or visit the Rayner booth, obviously. And can you join me in thanking Rayner and thanking our panel?